I know there are a lot of people here who are in other roles besides a medical doctor. We have social workers and therapists, psychoanalysts, nurses, other clinicians, maybe clergy even. And it is really, really important, I think, for you to know that we value you immensely. That you are our eyes and ears with the patient, because you may see the patient more frequently, or maybe more closely or more intimately than we might have a chance to. So I think it's important for you to hear this too, because if you see something that doesn't seem right medically with your patient, even if you don't have the certification to make that decision, your intuition is going to tell you something's wrong. And that maybe come to us and say, "Doctor, please maybe see this patient first. I'm worried about them. Something doesn't seem right to me." And that's very valuable knowledge for the medical doctor. And often, the psychiatric diagnosis is the last diagnosis. That I want to rule out or be sure it is not the other medical things first. So when I see someone with anxiety, I want to make sure they're breathing okay and getting enough oxygen. If I see someone with panic, I want to make sure they're not having a heart attack. If I see someone with psychosis, I want to make sure they're not intoxicated or having a medical issue, maybe their metabolism, their electrolytes, something off, their liver function, that could lead to an encephalopathy or difficulty with their brain thinking. So the brain and the mind are still connected. The mind and the brain and the body are all connected. And when I think of psychiatric things, I have to think of kidneys and livers and hearts and everything else. The most important thing is if there is something reversible medically, that we reverse it. If they're not breathing, let's help them get oxygen. If they're having trouble with their blood flow, let's get their blood pressure right. If they're having trouble with their kidney function and need dialysis, all of these other things can contribute to a psychiatric presentation. But I can give them psychiatric medications all day long, but if we don't treat the medical cause, I've done nothing. Right? Does that make sense? So this is an acronym in English that maybe won't translate so well in Ukrainian because the words will start with different letters. But I still want to tell you this because I think this is a very important thing that I use a lot. There is an acronym called I Watch Death. Every letter of that statement means something medically. And it is something that we think of when we see a patient with an altered mental state, or delirium, or maybe we think intoxication, or maybe psychosis, or hallucinations. I think I watch death. And understand this is in English, but the letters stand for infections, withdrawal from substances, acute metabolic derangement, so their electrolytes or something perhaps with their liver, trauma, head injury, central nervous system problem like a tumor, cancer, seizures. The H stands for hypoxia or low oxygen. This could account for carbon monoxide poisoning and other things like that. And the D in death stands for deficiencies, like vitamins, B12, folate, thiamine, niacin, B12, all of the important vitamins that have psychiatric implications. The E stands for endocrine, so this could be diabetes, it could be Addison's disease, it could be thyroid, parathyroid, pancreatic. And acute vascular, which could be a stroke, it could be hypertensive issues, heart arrhythmias, making the blood not flow correctly, shock. And the T stands for toxins and drugs. And H stands for heavy metals, so this could be poisoning by lead, manganese, and mercury. And in my time as a physician, I have seen every single one of these present as psychiatric. Where we get a consultation, they say, psychiatrist, please come see your crazy patient. Something isn't right, it must be mental health. And I'm going to give you an example. Oh, before I do that, I want to say the reason I watch death is relevant is because in people with altered mental status and delirium, they are over twice as likely to die in a hospitalization or later hospitalization than someone who does not have delirium. So it is very important that we monitor these things and that nurses are checking labs, that we are getting this information and trying to keep people normalized as far as all of these medical conditions and monitoring for intoxications and poisonings and all these other things. Because when people have changes in their brain, it makes them much more susceptible to whatever illness is ailing them and subsequent death. And I want to give you a little example. I was a psychiatrist on call, and I get called for an urgent consultation to the ICU. And there was a 67-year-old woman who had previously been coherent. She was speaking with the nurses. She was okay, but she was medically ill and in the ICU. And they said, we need to see you for acute agitation. She is trying to pull out her IV. We put her on BiPAP, which is oxygenation to help her breathe because she wasn't getting enough oxygen very well. And she is trying to pull off the mask. She is trying to hit the nurses, kick the nurses, throwing all the sheets off the bed. We need you to give her a sedative. We want to know what medicines to give her to sedate her. And so I tried to quickly show up, get to the ICU, and we do our doorway exam when we walk in. Before we even walk in and see the patient, how's the room set up, who's in here, what does it look like, what equipment is here. And I look at the patient who is agitated. She's kicking and yelling and trying to pull off her mask. And I walk around the patient and I look at the equipment and I look at her blood pressure, her oxygen is 68. It should be 92 or higher %. So very low. She's not thinking correctly, I'm sure. And I look at the machine that they just brought over to her for the BiPAP. And they have rolled the wheel on top of the oxygen tubing. So they were choking her to death by insisting that the mask stay on. Now, if I were being choked to death, I would be fighting for my life, which she was doing. So I quickly said, let's move the machine, let's get her breathing, take the mask off until we have this situated and fixed. And she was okay. And I said, I am glad we did not sedate her, because we would have killed her. So this is important to look out for these things. This is just one of many examples I can talk about. So let's talk about some of the things that overlap with PTSD. In particular, I'm going to focus on traumatic brain injury, or TBI, sleep disorders, and there are many. And briefly, we're going to talk about substance use disorders. I'm not going to talk deeply about how to do detox or medically treat them, but I do want to talk about where they overlap with PTSD and how I think about that. Dr. Harpus Roden will talk about the psychiatric comorbidities, including depression. So traumatic brain injury. We see this a lot, and we certainly see this a lot here in Ukraine, unfortunately. So traumatic brain injury is a sudden brain injury that affects the way the brain functions. This can be by direct force, it can be by blast injury, it can be by something we call shear stress, which means the heart is sort of turned quickly and the fibers of the neural tract start to shear and shred. And in the US, and I think worldwide, this is the signature injury of modern warfare. What this means is this is kind of the main injury of modern warfare. And I'm wondering if we can think about why this would be so prevalent in the modern era of warfare versus eras past. Does anyone have any ideas about that? Why is TBI so prevalent now? Explosions? Okay. We were pretty good at blowing people up in World War II. We've been pretty good at blowing people up for a long time. Certainly part of it. But what else might be a factor? Oh, microphone.
Раніше пацієнти не доживали до ПТСР після черепно-мозкової травми.
Wait.
Я перекладу вже.
Раніше пацієнти не доживали до посттравматичного розладу після черепно-мозкової травми, тому що зараз просто вищий відсоток виживання.
I'm not hearing, hang on. Wait, I'm having a problem.
Combat survived, the amount of combat that survived during the Second World War and First World War was significantly lower, and now we have much higher amount of people who survived after the explosions.
Yes.
And the duration of the life is different.
Yes, did everyone hear that?
Yeah.
Okay, so people survive more. Why do people survive more? Why are we surviving better?
Tactical equipment.
Medical evacuation.
I heard medical evacuation.
March.
Yes. So we are better at saving people at the front line. We are better at removing them from the front line to trauma center and doing rapid interventions within the first hour. Do you know what most people died of prior to the 1800s in war?
Bleeding.
I heard bleeding. What else? Infections. Yes, infections. Sepsis and infections, absolutely. Once we understood sulfur, penicillin, things that have killed the bacteria, we were better at saving lives. And now we are also better at saving lives. So this is why we have so much TBI currently. And many amputees as well. We're just better at saving people. The overlap between PTSD and traumatic brain injury, there are many things that are similar, like fatigue, insomnia, cognitive deficits, thinking problems, irritability, depression, anxiety, and I would even say headache, even though it's kind of on the TBI side here. So we see that there are many places this overlap. So sometimes when we see someone with PTSD and they have these signs, it may really be an underlying TBI. So we need to evaluate for that and ask the question, have they ever had loss of consciousness? Have they been knocked unconscious? How long did they stay unconscious? Did they have to go to the hospital? Did they need neuroimaging? Did they have to go to the ICU? Were any of your skull bones broken? Did you have memory loss? So there are a lot of questions we can ask about that. So certainly if someone is saying that they've had these experiences, especially a loss of consciousness over a couple of minutes, memory loss, needing to go to the hospital, we certainly want to have them evaluated further for TBI. So as we are better understanding the brain regions involved in PTSD, I just show you 4 maps here. We can see that there's many regions where if you had a head injury, it may affect those types of deficits. So not just are they in PTSD from the exposure to an emotional trauma, they can be from the physical trauma as well. So we can see similar types of symptomology, such as altered cognition and mood, the intrusive thoughts in sort of the frontal ventral part of the brain, avoidance in areas of the cingulate, amygdala, hippocampus, memory regions, fear regions, and altered arousal and reactivity in the anterior accumbens and the ventromedial prefrontal cortex. So we see that there's lots of regions that are going to overlap with this, so we can kind of think that it makes sense that we would have similar types of presentation. So traumatic brain injury has both direct effects from the initial injury and the wound, and it has indirect brain trauma. So when the brain is injured, it affects the function of the brain. So especially with shear stress, where neurons are kind of nerve pathways are kind of pulled apart a little bit, think of like a fraying cord, a cord that is coming apart, a string. That is kind of how we can think about these nerve pathways. So often we see injury to the hypothalamic pituitary adrenal axis, so the glandular parts of the brain, the pituitary and the adrenal gland. This has to do with there's a study that shows low histamine and hypocretin, which are part of these. This can affect sleep alterations specifically. So people with TBI tend to have very disrupted sleep patterning. This was higher, or there were lower levels of this in the cerebral spinal fluid in people with central hypersomnia. They slept too much. And narcolepsy, they could not stay awake and would fall asleep suddenly. So there's something about the sleep-wake patterns that are disrupted in this. And there are also things related to Alzheimer's disease and dementia. So if we look at the ApoE4 gene, when we have TBI in combination with the allele or the gene that is susceptible to Alzheimer's, we see earlier cognitive decline with people who also have TBI. Sleep apnea is more pronounced in people with TBI, perhaps part of this patterning of breathing, and also more effects on cognition. So I just show a diagram that shows, we know we have increased fight or flight, sympathetic activation, higher stress response is cortisol. Fear hits this. So when someone has a trigger that goes in through memory, has a fear response, it affects cortisol, the stress response, sympathetic activation. All of these can affect REM sleep, or rapid eye movement sleep quality, and the continuity. So these all keep us from getting into deep sleep. I'm going to show you that in a couple slides. So let's talk for a moment about sleep disorders. So the first thing I want to show you is what normal sleep looks like on an encephalogram. So they put the electrodes all over your head in a little cap, and you go to sleep, and they do brain electrogram reading. And what they want to see is the pattern, which is normal, shows this is like your wakefulness. You're at this state of high frequency EEG, alpha and beta waves. Not going to be a test, but just so you get an idea. High frequency waves, so you see faster waves on an EEG. And then you go into kind of this deeper sleep. So as you fall asleep, this is time, 11 p.m., midnight, etc. You start to go into deeper sleep, deeper sleep. You end up getting these little sharp waves, sleep spindles. As you're starting, you know what this feels like, right? Because it's like that thing. You get deeper sleep, deeper sleep. And then you go into what's called slow oscillations or delta wave sleep. This is really important. Delta wave sleep, or this deep sleep, you do dream in it. You tend not to remember the dreams. But it is where our memory goes from short-term to long-term memory. It is where our immune response gets regenerated. It's where blood pressure and blood sugar control is improved. So people who don't get into this deep delta sleep, these red circles, tend to have problems in all of those. Truthfully, probably me too. I mean, I'm a doctor, I'm busy, I wake up in the middle of the night, I'm on call. My sleep's disrupted, my blood pressure's up. I know the nights that I have this, my blood pressure is higher. So I try to do what I say, but not always. So the way this should work is you go into your first deep sleep cycle, and then you come up to this light REM sleep here. This is where we have kind of the dreams we remember. And we have the rapid eye movement, right? Your eyes are kind of going. I'm trying to mimic this. Your eyes are going in your sleep. Because think about it. We want our brain to turn off our movement when we sleep. It turns off everything but the eyes. So my muscles are not acting out my dreams. I am not walking in my sleep normally. I am not going and cooking a meal in my sleep, even if I'm dreaming about it. But it doesn't shut off the eyes. That's why we have rapid eye movement. Sometimes, at this point, we wake up. And I would say the gentlemen that we rounded on yesterday wake up there. They get their first deep sleep cycle, if they get deep sleep, and then they wake up here, and they don't really go back to sleep. That's what happens in PTSD. You get that first cycle, and then it's enough, and you have so much norepinephrine, you can't go on to the other cycles, which is what normally we would do. We would go down into our next cycle, and our next one, and our next one, and our next one. But you see, they're not usually as long or as deep as the first one. Like the first one is very solid. This might be a little interrupted, a little more interrupted, and this one might not even go into the deep sleep, and then we wake. So we often wake remembering our dreams because we wake typically in a REM cycle, unless we're woken by something like an alarm clock. So does this make sense? Does this feel like what you know when you sleep? Like how usually we get up after an hour or two and go to the bathroom sometimes? Yeah, that's what happens. So this is a graph from the US military. I'm not exactly sure how it would compare with Ukraine. But in this example, we are looking at the percentage of people with so many hours of sleep. So people with more than 9 hours are in this light blue, 8 hours, 7 in green, 6 in orange, and less than 5 in red. And we're looking at the Air Force, the Army, and civilians who were never in the military. And if we look at the percentage of people who have more than 9 hours of sleep, we've got about 9% in the general population. And about a third of people get 8 hours of sleep. The recommended sleep is 7 to 9 for good sleep. And we've got about another third that gets 7 hours. So it looks like, 2/3 of the population gets over 7 hours of sleep. And then we get down to the 6, is 20%, and we get down to less than 5 is only 8%. But if we look at our military, do we see that the vast majority of people are getting less than six or less hours of sleep, right? So we have 42% getting less than 5 hours. Now that's not necessarily PTSD or TBI. That's just people in the military, because it's very disrupted. And you learn to function on little sleep. And we look at people who have restorative sleep, 7 to 9, we're looking at around 30%. So 2/3 it's completely flipped over, right? 2/3 are getting really bad sleep quantity. So I would assume it's probably pretty similar here, maybe even more extreme here because of the active war, right? People are not getting good sleep. And if we look at the types of sleep disorders there are, in order of prevalence, we see insufficient sleep or just not getting enough sleep is the number one thing. And after that is mild sleep apnea. There can be mild, moderate, and severe. Mild is by far the most common. And then comes insomnia, which is the inability to fall asleep. We should fall asleep within about 20 minutes. If it takes us an hour, that's probably too long physiologically. We should be falling asleep sooner. If we get around that time, we're going to call it insomnia. If you're falling asleep very, very quickly, within 5 minutes or so, that means you are sleep deprived and you have what's called pressure to sleep pressure. So as soon as you close your eyes, boom, I'm out, right? We've all had days like that. And next, the fourth on the list is circadian rhythm disorders. This can be shift work, certainly hospital work, delayed phase, meaning we should be up at basically sun up and down at sundown. But what if we're night shift? What if we are split shift? We work twice a day somewhere. So these things can be very disruptive. Number 5 is restless leg syndrome, where people feel the need, they have to keep moving, and they can't settle down. That can be related to ferritin transferrin, the iron system of the body. And parasomnias. Parasomnias are things around sleep. That could be sleepwalking, sleep talking, sleep eating, sleep cooking, sleep driving. Very dangerous. Yeah, what?
Can you clarify what do you mean by sleep driving? Is it the
So getting in the car and driving when you're not awake. Part of their mind is awake, but they are not conscious of it, and they will dream they're driving, and they will get in the car and drive. And we're going to talk about this because this is really dangerous, and this has to do with some medications can cause sleep disruption that leads to parasomnias. So we want to be super careful. And hypersomnolence, which means you're too tired all the time. There can be narcolepsy disorders and things like that. Any questions on this slide? So some of the things that we know in sleep deprivation, when you're getting less sleep than you should for whatever reason, any of those reasons, we know that there is, if you sleep deprive people for one night, their amygdalas, the sort of anger, rage, fear response part of the brain, is 60% more active. So if you, So if you look here, this is normal sleep, and this is without sleep. The areas of the amygdala on both sides of the brain are more active, meaning that amygdala is kind of ready to go and doing a lot more blood flow according to this image. This is a bold fMRI. So looking at blood flow, we assume that there's a link, we know there's a link between activation and blood flow. And the connectivity in the sorry, it says medical prefrontal cortex, it should be medial prefrontal cortex. The connectivity between the medial prefrontal cortex and the amygdala is decreased, which means the ability for the prefrontal executive functions of the brain to control the fear response and getting irritated at people and being quick to be angry is not controlling it very well. So this is why if you don't sleep all night, you're grumpy, right? So if people are chronically not sleeping, you can imagine they're irritable. We know these people, we've met them. We can be them sometimes. So it's kind of like the prefrontal cortex is pushing down the foot on a brake, but with the lack of sleep, we're lifting up that brake and the amygdala is just running. Okay, questions? So insufficient sleep, for whatever reason, we know there are lots of effects. So this study here showed that nearly a third of people get 5 hours of sleep or less per night. And this is related to an increased risk of mental health and physical problems. So trying to get sleep closer to 7 hours is something that helps your physical health as well as your mental health. And insufficient sleep impacts cognitive performance. They did a study of medical students and residents who worked night shift, and then they evaluated them on a driving test the next day, and they scored worse than someone who was intoxicated on alcohol. So it does affect cognitive performance. This reaction time, if you're driving and someone pulls in front of you, your reaction time is slowed down with sleep deprivation. Lots of other thinking tasks. Immune function. Pain tolerance. Pain hurts more if you're sleep deprived. Another reason for the gentleman on the unit to be getting good sleep. Ethical decisions. How we make ethical decisions and being able to put ourselves in the context of another person. Can I see it from your perspective when I'm making an ethical decision, or I'm seeing it just from this very egocentric self? We are more selfish when we are sleep deprived. And emotional processing. How many of us make really great decisions if we haven't slept all night? No. How many of us have had a bad breakup when we didn't sleep all night? Right? So we can make some poor decisions that can affect our relationships and work and everything else. Did you want to picture that last one? And sleep disorders worsen suicide risk. So in this study, it showed that there was a peak in suicide between 2 and 3 a.m. When we are assuming people have insomnia, they're not sleeping normally, they're getting poor sleep quality, or perhaps nightmares have woken them. 70% in this study was also with alcohol intoxication. So if we look at this diagram, we see the effects of sleep deprivation that go from suicidal ideation to suicide attempt. So this is a suggested pathway where we have decreased cognitive inhibition. We're not likely to say, no, I shouldn't do that. We have impaired decision making. Yeah, that bad idea sounds really good right about now. We have a deficit in risk and reward processing. So how risky is this? I might think I'm very brave and I can do these things that I shouldn't be doing because they're too risky, but my judgment is off. And emotional dysregulation. I am not going to control my emotions very well, which can lead to this cycle that increases impulsivity, going from ideation to attempt, which certainly can happen in the context of poor sleep. Make sense? Any questions on So briefly, we're going to talk about treatments for sleep disorders. Typically, the main treatment when we think of sleep disorders, we think of sleep apnea. So people that stop breathing while they're sleeping, this may be for a second or two. It's kind of like, they're breathing and then they kind of do that. The person usually doesn't know they have it, but their bed partner will know. And they'll say, hey, wake up, you're not breathing. It's scaring me. That's usually what we hear. We usually hear the wife come in and say, he frightens me every night because it sounds like he's going to stop breathing. So that can be from being overweight and having more physical constriction of the airway, but it can also be from central dysregulation where the message to breathe is not going correctly, which happens with PTSD. So we see these young, fit men and women who don't seem to be overweight at all, that have sleep apnea because of a dysregulation, usually of the norepinephrine system. So treatment is usually by CPAP, or continuous positive airway pressure. So have you all seen the CPAP masks and the little machine that people breathe with at night? It kind of applies a pressure, it blows air into the mouth, moisturized air into the mouth. It kind of forces the airway open. It's like if you just were blowing, I don't know, how do I think about this? Like if you had a little hose blowing air into something, it just holds it open. That's what it's doing. So treatment works. It helps. It helps people get better quality sleep through the night. Their oxygen doesn't drop, their brain doesn't lose oxygen. But it's a little bit tricky to wear. Not everybody likes wearing it. It takes getting used to. We have behavioral techniques that help them adjust to it. We say, wear it in your comfortable chair after dinner for 30 minutes while you're watching TV the first few days. And then wear it for an hour while you're watching a television show. And then try to wear it for the first part of sleep. Maybe you'll take it off, that's okay. And then wear it a little bit longer and a little bit longer. We can do shaping behavior that way. But a lot of people don't like wearing it. And there are other oral therapies. There's different ways to do this. You can have a mask over the whole mouth and nose. You can have nasal pillows, which just go to the nose. But if people open their mouths when they sleep, the air just blows right out. So they have to be people that sleep with their mouth closed. There are oral devices that kind of go into the mouth and hold the jaw open and forward a little bit, which keeps the airway open. So there's lots of things that we can do. There are rules for alternative therapies and sometimes sedative hypnotics, but that depends on the type of sleep disorder. So if someone is sleeping too much, hypersomnia, we might use something like modafinil to keep them awake more, a stimulant. There are other things that we can use. We talked about the sleep medicines yesterday. So like Lumesta, Sonata, those Zolpidem, those sleep medicines can be helpful. The problem with those sleep medicines is they can affect the sleep patterning so that we don't get the same deep delta sleep. They can also cause parasomnias. So sometimes when people take a sleep medicine, they may be more likely to sleepwalk. We don't want them to fall down the stairs. I know people who have got up and cooked a lunch in the middle of the night on the stove with fire. And we know people that have gotten in their cars. Sometimes they find themselves on the side of the road down the block and they don't know how they got there. So we need to be very, very careful with these. So usually start it with someone present in the house in the same bed so they know if they get up and start walking away. The other thing is to take it right before bed at the bedside because you'll fall asleep fairly quickly. So the other thing is medications often don't give us normal sleep architecture. It gives us sedated sleep, which is not the deep delta sleep. It keeps us in the mid-range. When I think about a plan to restore someone's sleep, I want to get the most natural sleep possible and not just sedate them. Think of alcohol. People drink alcohol and they say, oh, it helps me sleep. It helps you fall asleep, but it doesn't give deep sleep. It gives restless sleep through the night. So it's not the same quality. So when we think of sleep quantity, the number of hours, how interrupted it is, but also think of sleep quality, how good of sleep it is, how deep of sleep you can get. And PTSD should be considered a high-risk barrier to therapy because people with PTSD are less likely to be compliant wearing the mask because they don't like to feel choked. Think of people who have a trauma where they've been choked by someone. It's very scary to feel that. Or people that need to feel alert and awake and they don't want the sound drowning out so they can hear the room. So they're less compliant with it. Beards, facial hair can get in the way of it. And people with PTSD tend not to respond, when they do wear it successfully, they tend not to respond as well, as easy. Hi, I remember you. Some people here I've seen that I didn't see before. So from Warsaw, so good to see everyone here. So considering it a high-risk barrier to effective therapy, when we have PTSD, we need to be really careful to try to give good education about why we're doing it, give a good transition to shape the behavior to allow them to accommodate to wearing the mask. Think of alternatives if the alternatives are appropriate. Any questions on the sleep section? Everyone awake? All right. So just briefly, I'm going to talk about substance use disorders. The main thing that I want to say about substance use disorders, which I think is most important, is we have to weigh whatever treatment we would like to do with the patient with treating the substance. So I have to make a decision. Do I start them in psychotherapy or do I get them into substance use treatment, or do I do both? So it depends on how much the drinking gets in the way of everything else, or whatever the substance is. If the substance is really a primary problem, it really needs to be addressed first. If the substance is medicating, self-medicating the symptoms of another thing, I may be a little bit more tolerant in saying we're going to work on trying to reduce the use, maybe not get rid of it completely, but reduce it while we work on the other symptoms, either through medications that are safe with that substance, or talk therapy, or both. And my hope and my experience is that as we successfully treat PTSD or whatever other issue is going on, they need the other medication or substance less. They need the alcohol less. They need the drug less, if it's marijuana or whatever else they're using. Always being careful of interactions of medications and the substance. But sometimes if I really want to work on successfully treating what's bothering them the most, if it's PTSD or depression or anxiety, because then if they have adequate, appropriate medication, they don't need the self-medication. Does that make sense? Okay. So we always have to balance this. There are some clinics that say in order to do the work here, you have to be completely off of alcohol, completely off of benzo, completely off of marijuana, and sometimes that's perfectly appropriate. You just have to gauge it for your patients in your clinic and your goals. Now, what I feel like mostly is I'm trying to balance things like this crazy balancing act of everything else. All right. So I just want to overview the main classes of substances. So alcohol. When I'm thinking of PTSD and alcohol, most often I'm hearing that they're using it to medicate themselves. They're using it to either help kind of increase avoidance. I don't want to think about these things, so let me just get drunk and I won't think about these terrible intrusive memories. They're using it to sleep because they have insomnia or they're having the nightmares. Doesn't give the good quality of sleep we talked about. I want to be careful, especially if they have a tendency to go into withdrawal. I always want to ask, do you get the shakes or sweats if you stop drinking? If you talk about withdrawal and they say, I don't ever have withdrawal, you can't stop there. You have to say, do you stop drinking? Because sometimes people just don't stop drinking. As soon as they begin to have any kind of withdrawal, they start drinking more. And they stay intoxicated and keep withdrawal away. So let's always ask, if you stop drinking for 2 days, do you get the shakes or sweats? We also need to be really careful of this in the hospital because people will come into the hospital for accidents or other reasons unexpectedly and then maybe go to surgery, and then 2-3 days later, they are in complete withdrawal because no one knew they were drinking as much as they were. So we always want to watch for this if we see anything. If someone starts getting shaky, sweaty, they're seeing things in the room, that's delirium tremens, right? They're delirious, seeing things, and they're tremulous. Usually it's visual hallucinations, not so much auditory or hearing things. But those are the considerations I think about in particular. Benzodiazepines. When I think of the way the medications work, I think of alcohol and benzodiazepines together because they have the same sort of inhibitory effect on the brain function. And when you are chronically inhibiting the brain and then stop the alcohol or stop the benzo, the excitatory system jumps up and all of a sudden we get the symptoms. We get the shakes, we get the lightning down the arms, feel like pins and needles, we get the hallucinations. You can think about this like these are all symptoms that are added to your brain because it's over-responsive. Extra things that you get, the extra feelings, the extra seeing things. So specifically for benzodiazepines, and some of those, for example, would be lorazepam, diazepam, alprazolam, or Xanax. There are others. For both this and alcohol, why I have this in red is because these are dangerous withdrawals. So when someone withdraws from either of these medications, they could have all of these symptoms that I talked about, and including seizures and death. So this is different than opiate withdrawal, which is extremely uncomfortable, but physically won't kill you. And stimulants don't have the same sort of tight physiologic withdrawal, but they do have, if you think of stimulants being things that make you feel elevated or good or high, like cocaine, and then you take it away, you feel the opposite. So you're low and tired and you're crashed for 72 hours. So you just kind of think of the opposite effects in the withdrawal. So particularly with PTSD, people like benzos because it helps with their anxiety. And people with PTSD feel anxious. So they might be using these, and we want to be careful. And remember yesterday we talked about benzodiazepines as like a pharmacologic avoidance. So when we think about PTSD, we want to avoid the thoughts and feelings of the memories and the regrets that we have. And one way to do that is to kind of sedate ourselves. We can become a workaholic, we can do lots of things to keep ourselves busy, we can drink, we can drug, we can use things like this. So with PTSD, this is how I often see this. So we want to educate our patients about it's difficult to, I'm going to back up. when I talk about this, I like to say, if I feel anxious, as say I'm going to go to Dr. Barazuk, but Dr. Barazuk is very scary and he's been very mean to me. And I'm coming close and I'm getting really nervous and really anxious and really nervous and really anxious. And then I go, oh no, I'm not going to talk to him today. I'm going to go over here. That avoidance teaches us that the next time I start to feel anxious getting near him, the best thing for me to do is to leave. The thing that helps is if I actually come up to him and I say, hi, and he says, you're okay, good job. And I say, oh, that wasn't as bad as I thought. And then I learn that that approach behavior is all right and it's not scary and I can continue it. That's exactly how we need to think of PTSD. We learn to stay away from the thoughts and feelings that bother us, and if we continue to stay away from them and pull back from them, which does feel better, it isn't therapeutic. The therapy is actually to approach it and to tolerate it, like Dr. Herbes said, to monitor our anxiety level, bring our anxiety level down with the SUDS, the subjective units of discomfort. I'm 80% anxious over here by Dr. Barazuk. But if I breathe and I think and I calm, okay, now I'm 30% anxious. I know I can do that. Same thing with PTSD triggers. Not that you're a PTSD trigger.
For someone.
For someone else. Does that make sense? So benzos do the same thing. They are like the avoidance. I'm going to numb my mind so that I don't feel those things, which is the opposite of what we need to do in therapy. It may be important to do that in the acute state, when they first come to the hospital and they need to calm down. But when we're talking outpatient or longer term therapy, benzos are very counterproductive. And then opiates, what I would say for that is they're used for pain, they're used for sleep, they're very addictive. People tend, for all of these, they can escalate use, increase it more and more over time. We do want to watch out for the withdrawal for this as well, which looks different than benzo and alcohol withdrawal. So this one gets the stomach cramps, they wear the sunglasses because it's too bright, their pupils are dilated, they may be sweaty, their nose runs, their eyes water. And there's medications we can use to counteract all of this in detox. And we might be thinking of a replacement therapy like methadone or buprenorphine, replacement therapy to switch out the drug for medication and then slowly taper that off so they don't go into withdrawal. There's lots of ways we can do it, but if you think of this, think of pain, right? And opiates, chronic opiate use, leads to something called hyperalgesia, which means pain feels more painful. So the nerves are sensitized or more active, so hurts more with chronic opiate use when you're not using the opiate then. So these are just the considerations that I think about when I think about my PTSD patients and the combination of medications. Usually I'm moving toward another medication plan of something that's more appropriate for them. I may be switching them to a different class of medicines. I still want to address their pain. I can't say give everything up and then we won't treat you for your pain. I've got to treat the pain. Maybe duloxetine, maybe gabapentin, something else that may work for that too. But these are the thoughts I have about that. So let's see. Any other questions about substances? Okay, so that ends my portion of the talk. We're going to go on to the mental health comorbidities, and I'm going to leave this slide up to just look at it, but thank you for your kind attention.
So we'll just, the diagnostic, the DSM is a mess. So we want to take it with a grain of salt, because there is huge overlap between many diagnoses, and that makes the decision very hard. So I want to try to look more at cluster of symptoms, how symptoms come together that will drive your decision how to treat the patient, either pharmacotherapy or psychotherapy. So I'll show you another way to step back a little bit from the DSM. Okay? So I mentioned it earlier, when you take a group of people, like in the VA, in our VA, with acute substance use disorder, a large proportion of them, more than like 80% most of the time, have PTSD. So when you encounter a patient with substance abuse, most likely they have encountered trauma in their life. But if I'll go to the PTSD clinic, not all my patients have substance, not the 80%. We're seeing around 50% of the patients. So, depends where you go. It's very different, depends on what is your major diagnosis. And Shelley talked about how to intervene, and even in substance abuse, I'm just mentioning, we have a trial that people do the trauma written exposure while they're going through opiate use treatment, because opiate is a really big problem in the US, hopefully not here. So opiate use is big, and why to wait? And it seems that if they are engaged in this kind of treatment, they're less likely to drop out of the opiate treatment. So it's really interesting that they can deal with that, not in a level of PE. I didn't do a trial, maybe it will work, but the person in the opiate use disorder wanted to use WIT, and I worked with them. Okay, let's start from that, and it's working well. So a lot of people when you see patients with substance abuse, always you need to listen to the trauma. Okay. When we're looking at the U.S. Veterans Affairs, large proportion, between 30 and 50%, depends on where clinic we are sampling. So when we have a specialty rehab, like residential treatment program, that people with severe PTSD go and stay for 3 months. It's not a lock unit. They can have pass, go outside, but it's like every day, all day, and they sleep there. You have like almost 50% MDD in those groups, in the severe PTSD, and outpatients are ranging around 30%. We also see high rate of anxiety. And high rates of OCD too. Okay? And already Shelley talked about TBI as part of this. I don't want to go again over this. I want you to memorize. You're going to have it, because that's how complex PTSD is. And again, Shelley gave me a very good one. So we're talking about the intrusion, that internal intrusion, the psychological reactivity You know, you see something, you get very activated, you're constant, hypervigilant and worry and jumpy. Like, obviously that's tremendous overlap with anxiety disorders. People that worries and afraid or phobia, huge overlap. So we treat it in one way, the blue. We treat that as memory reconsolidation. We talk about those cognitive, and I will highlight later with other depression symptoms. You know, MDD, specifically rumination. You have this rumination, overthinking, oh, I'm a bad person, or I'm a failure, I'm not good, whatever, like not related to PTSD. Unresolved grief. You know, you lose someone and you're unable to let go of the grief. This is kind of a rumination that's going on. So again, huge overlap. Sometimes we tend to think about it as PTSD, but it's unresolved grief. Okay, and Shelley talked about the sleep, but too many. So this is a very busy slide, but I will try to work with you on it just to think. So in PTSD, you have questions in a PCL. Do you experience fear, horror, shame, and guilt? That's two different biological mechanisms. So we say, let's ask it separately. Are you feeling horror or fear? Question one. And question two, are you feel shame and guilt? Because are those really separate concepts biologically? And we say, okay, there is also blaming, you know, but you can blame yourself and you can blame others. It's two different thinking. Blame self, you really like digging into your own soul. So we separate those questions to two questions. And then we gave it to 2,000 people with post-traumatic stress disorder. And this is called network analysis. It's used in MRI and a lot of other, but you can see the relationship between symptoms and concepts controlling to the all other relationships. So it's give you words like sicker blue, more connection, taking account all the other things around it. So it's give you the centrality, the central things that happening in that human. So of course, if you blame other, you are much more likely to be connected to the anger. Okay? You really like feeling this anger. It's not agreeing the self. Let me find, when we're thinking about fear and horror, we separate them. You see, it's creating you very jumpy, you're very startled. That's related to hypervigilance. Fear and horror, you have the nightmares, flashback, physical reactivity, memory reactivation. Those are really strong cluster of network. When we're looking at guilt and shame, when you blame yourself, what does that look like? It's really activating the shame and guilt and negative belief about self. So they're all not related. You can see that sleep, of course, because of the nightmares related to the memory, anhedonia, and trouble having positive emotion. So it's kind of separate. Again, as I mentioned, you have to look at that Okay, the person blame himself, most likely gonna be very feeling guilt and shame, very strong guilt and shame, but very negative belief about themselves, and very hard time feeling any positive emotion related to anhedonia also, you know. Totally different system than the fear system that is all there, and the anger, irritability that blame other. So it's very hard to, sometimes even the questionnaire are problematic. So just give you the direction that what do you want to treat the patient here. So I try to simplify that, and we took that and, okay. So people that have a very high fear, of course, have re-experiencing, okay? And re-experiencing related to avoidance. Also, what we call emotional pain symptoms. We ask patients what did they feel, you know, how the level of experience of emotional pain. Emotional pain is, we know that it's highly related to physical pain too. And we have now studies that link them together through the endocannabinoid system, but we don't have time to look at it. And we look at rumination, okay? And remember, we talked about negative cognition, about how you think about yourself and other. That's not related to re-experiencing. In order, if you have this kind of negative thinking, you have to score high in rumination in order to have re-experienced it. You're not having a direct relationship between those concepts that you are a bad person unless you have rumination, high score in rumination scale. So you will want to try, and again, when you put anxiety, GAD-7 questionnaire, it doesn't create re-experiencing. You know, you jumpy, hyperarousal, like PTSD you look like. If you want to, and you have very strong rumination around those ideas that, you know, this is dangerous, or tomorrow it's going to be a horrible day. So you can see that fear is not related to this concept of negative emotions that we talk about it. So we have more and more, this is 2,000 people that we sample, that really show those separation that we talked, and how you want to approach patients differently than directly thinking about DSM diagnosis. More mess. Again, it's just to show you that this is really working. And this idea that we're trying, and this is, we did it with Or Dweck, my postdoc, and now, you know, a faculty in Israel. So we took a PHQ-9, and with PCL, at the time it was PCL-17 when he was postdoc in my lab. So let's just look at something. I'll just take suicide, what we want to look at. I'll say like PHQ-2, feeling little energy. Okay, PHQ-2, wow. Let's go through the strong relationship between PHQ-3. PHQ-3 sleep problem, of course, will be related to the sleep question in the PCL. Number 13 is sleep problem. So you're going to see that it's related to PHQ-4, little energy, and PHQ-5, poor appetite. Those a whole system that derive itself. But the PHQ-9, PHQ-6, and 2 are all together. 1, 2, and 6. 1, little interests, feeling depressed. 6, negative thought of feeling. And they are related to PCL-12, feeling failure, you see? So I'm feeling failure, and PCL-9, no interest in anything. So you see, it's all clustered together around this self-failure, also driving the depression symptom. Very different, of course, from the hyperarousal reactivity or other. They all separate nicely, all the re-experiencing, separately from depression. This is a very unique signature that we talk about memory reconsolidation. And PHQ-9, it's interesting. Let's look at PHQ-9, the suicide thoughts. PCL-10. PCL-10, feeling very isolated, so very important to have social support. And PCL-12, I'm feeling a failure, like I'm a bad person. I messed it. Really high relationship, relatively high correlation to suicide thoughts. Okay, and PCL-8, you know, amnesia, that's not remembering part of the trauma. When you really like dissociate, those are driving a little bit. So again, what I'm advocating for you, you have to think about depression, anxiety. Anxiety really acts as a rumination processes and time of intrusions, but not related to the type of memory intrusion that we have in PTSD that are really fear-based. So we tend to take, again, moral injury. And the way that we are thinking about those people that are ruminated about things that related towards PTSD, we want to treat it differently, more like as a depression when we treat that, and not treat it as PTSD. So making you work through that. If you have moral injury and PTSD, you can solve the moral injury with a PTSD treatment. But if you have someone without those fear, this organization of the memory, because it's too scary to deal with it, if you don't have it, you don't have to do PTSD treatment. So you make sure that you adjust your treatment to the right treatment, to the right diagnosis. So kind of making you think about it in a new way, moving away from the strict DSM and try to think about what symptoms cluster the patients are showing you, and then try to think what will be the best medication and intervention. So when you have overgeneralization of fear, you're afraid of a lot of things, you avoid a lot of things, you know, OCD, you know, a lot of in vivo exposure. Best treatment for PTSD, for OCD is something like the in vivo of PTSD is exposure and response prevention. Very hard, painful treatment. Anyone here ever tried in vivo exposure and response prevention with an OCD patient? Very hard. You have to take the patient.
У нас у Львові був вибух внаслідок попадання ракети у будинок, і постраждали діти. І я працюю з дітьми, і у них були інтрузії. Ми робили експозицію, травмофокусовані, стабілізаційні вправи. І коли ми вже закінчували цей процес наш, це тривало приблизно 3 тижні. Останній наш тиждень був присвячений ін-віво. І слава Богу, у нас в лікарні ведуться ремонти на багатьох поверхах. І в підвалі. І ми працювали з тим, щоб діти могли зайти в приміщення, де є цей пил, мікропил, який після вибуху організовується в повітрі. Є звуки, які це буріння стін, це такі несподівані звуки для дітей. І їм вдалося, нам вдалося, і зараз діти навчаються в школі, ходять спокійно в укриття і не мають проблем.
This is so nice to hear. It's amazing. How is emotionally for you to do this treatment with the children? Is it difficult or?
Це вже не перші діти, з якими я це проводжу, тому я знаю, який буде результат насправді, я впевнена в цьому результаті, і мені подобається спостерігати за змінами, які в них. Але насправді це маленькими кроками йдеш, наближаєшся до цього підвалу ще здалека, Ну, тобто оця шкала суб'єктивної оцінки стресу використовується також з дітьми, просто не до 100, а до 10, і ми так поступово наближаємося до тих таких найбільших, найгарячіших точок їхньої травми.
Thanks. That's so important, I think, for other clinicians to hear. That if you stay consistent and you're not, overwhelmed by anxiety that you are really doing something bad, re-traumatizing, people get better. You are really, and to go with someone that need to lock everything and say, no, you're not locking. And they stay in the panic, they're thinking that someone will break into the house and something. And, of course, there is a chance, but it's small, very small, and 99.9% of all those exposures, nothing bad gonna happen. I have no connection to our power, but, maybe, but it's doesn't happen. And, maybe one day will be misfortune, but this is always a chance. But again, you're doing it, and you're doing it consistently, and it's hard. People get almost panic attacks sometimes in those situations. When you ground them, but this is exposure really works for OCD, works for anxiety, okay? And you just want them to stop doing what they're doing that doesn't make sense. It makes sense to them, but taking into account everything, that they need to be able, to realize, there are some germs, but they're not going to kill me on my hands, so I'm not going to wash. If you're afraid to go, you're going to stand and stay with the anxiety. And you see, with kids, it's really so important. Going back to school, being back of society. When you have these intrusion thoughts, okay, can be fear, anger, guilt, and shame, okay? And we talk about that. What are the meaning of the intrusion? Remember, I showed what is driving the re-experiencing in guilt and shame is the rumination. If you don't have rumination tendency, if you learn rumination, I can feel guilt and shame, but I will not have the re-experiencing that all the time it's coming back. Okay? If I don't have this rumination component with GAD, remember? You're not going to have this intrusion. So, for the fear, you're creating a story, correct? With a meaning. You take all those memories that are not connected back to a whole narrative story. But with, guilt, shame, rumination about anxiety, you try to understand where it's coming from, in addition to the exposure therapy, because you need to break out the rumination and know why you're ruminating. You have to find the meaning around this depression or anxiety as you're looking within PTSD, but you're not doing, in vivo, you're doing your own spiel, psychodynamic, CBT, whatever your modus operandi. You go with it, and you need to bring meaning to that behavior and untangle the rumination. Again, I highlight rumination and unresolved grief because those are sometimes really misdiagnosed and get mixed with PTSD. So always pay attention that someone is not really dealing with unresolved grief, and we try to treatment in PTSD. That's overkill. You don't have to go there with them. You need to really understand and process the loss of the object with those people. Although it's involved maybe in a war, but they're not afraid of it anymore. It's not involved in fear. So make sure you separate those. It can be a very horrible death in an explosion, or but they already went over those issue of fear, and they don't have it. Don't overdiagnose PTSD. Okay? And we know Shelley talking about TBI, and we know there is a lot of, and you have weaving now, this combination of cognitive rehabilitation. You're doing physical therapy, you're doing rehab. That's how you want to work with TBI in conjunction with trauma-focused therapy if someone has PTSD. So again, I want you to think away from the DSM and look at the pictures and the way that people present in front of you, and not by the book that has a lot of problem with it. So hopefully, with those colors that I show you 20 times, it will give you a way to think about the patient and how you treat them in medication or psychotherapy based on the symptoms cluster, not the diagnosis yes or no. Because I can spend a whole hour to show you how many problems, if you take different models, this system of DSM has. So always, follow the patient.
I have a question about your clinical trial. What is your expectation about the trial?
We thought that because 80% to 90% with individual with the opiate use disorder do suffer from PTSD, why to wait? They will finish the treatment. And we thought that the written exposure therapy is kind of a very soft approach to them to engage with the trauma with not highly, stressful, and we don't have 25 therapists. Most of the people working in the substance abuse clinic are, they're called counselor, substance abuse counselor. So that's easy for them to do the written exposure. They don't have the skill to do prolonged exposure. Not psychiatrists, psychotherapists. They are substance abuse counselor with, very limited. So we thought that will be good, and we showed that they like it. They give them opportunity to speak, let out the trauma in a very, constructive. I wish we had art therapist, like you have here in the substance abuse, that can also work with them through art, but they're more likely to stay in this treatment, and they're feeling that there's PTSD getting a little bit better.